My name is Taylor. I'll be your instructor today. We're going to be reviewing the nursing newborn assessment. It's going to consist of the APGARs, scoring, vital signs, and then head, ears, eyes, nose, throat, and mouth assessment at this time. My email's down there if you need to contact me. So just to kind of give you an idea of what we're going to do today, we're going to review our objectives, present the material, and then we're going to do a brief case study. And then at the end, I'll allow some time for you guys to ask questions, and we can talk about things if you have any things that aren't clear to you. Oh, sorry, my slides got away from me here. All right, so our objectives. They start with, by the end of today's class, you'll be able to describe the purpose and components of the APGAR score, evaluate the normal vital signs of a term infant, describe the components of the head, ear, eyes, nose, throat, and mouth exam, compare the abnormal and normal findings of vital signs in the head assessment, and interpret the assessment findings to appropriately care for your newborn. So we're going to begin with the APGAR. APGAR is an acronym. It stands for Appearance, Pulse, Grimace, Activity, and Respiration. This is just a subjective assessment of the infant's transition from intrauterine to extrauterine life. So it's very dependent on whoever is assessing the child at the time. It is not an indication of morbidity or mortality outcomes. It's just purely an assessment of how the infant is how well they are successfully transitioning to extrauterine life. Appearance is where we begin, and it starts with the color of the skin. Could be pale, cyanotic. Initially, the infant will be will appear cyanotic, excuse me. They'll have blue hands and feet, but they should be pink along their trunk and their face, and this is typical for about the first 24 hours of life. Next is your pulse, which is your heart rate, which you will do in the left mid-clavicular line at the 5th intercostal space. And then your grimace, which is the reflex irritability based upon gentle slapping of the soles of the infant's feet. So you should gently slap their feet, and they should have a good solid cry in response to that. Then activity level, which is the baby's tone. So their hands and feet should kind of return to that midline positioning that's similar to the fetal position that they were in utero. And then finally, respirations, which we all know how to calculate respiratory rate. The score is on a scale of 0 to 10, 10 being perfect, which you rarely ever see in practice. Most babies have some acrocyanosis at birth. So typically, you're never going to have a score of 10. 0 to 3 indicates severe distress, so they're not transitioning well. 4 to 6 is moderate distress, so some moderate interventions can be applied. And finally, 7 to 10 would be an appropriate score for a newborn infant that doesn't need any intervention. Anything less than 7, there needs to be an intervention provided. You score these at 1 minute and 5 minutes of life. And if the infant is scoring less than 7, you continue to score until 20 minutes of life. This is an example of acrocyanosis. You can see that his feet and hands are blue while his face and trunk are still pink. So this is a normal appearance of a newborn immediately after birth. This is just the APGAR chart. There's a link embedded here in APGAR that you can follow that actually will demonstrate how to appropriately perform an APGAR score, which I suggest you do at the conclusion of class and when you're studying for the exam. Each acronym, heart, respiratory rate, muscle tone, reflex, irritability, and color, has a corresponding reaction or appearance that the infant should have, and each one is rated on a 0 to 2 scale, and then you add these up for a total, which is our 0 to 10 scale. All right, so now we're going to move on to vital signs. General appearance, just looking at the infant, they should be slightly flexed, as I mentioned. Fists should be clenched, and spontaneous movement should be happening. Their temperature, you want to measure that axillary. Typically used to be rectal, but we've moved away from that. It's no longer a good practice because you could perforate the anus. The idea was you do it rectally to check for a patent anus, but that's not necessarily proven to be effective anymore. The infant should be stooling regardless by 24 hours of age. So there's no reason to go ahead and check rectally and cause trauma. So axillary temp, and your normal values are listed over here. That should be stabilized by 8 to 10 hours of life. Next is your heart rate. You inspect, palpate, and auscultate, which I mentioned earlier is left midclavicular fifth intercostal space. Respiratory rate, you observe at rest and count for a full minute. So infants have irregular breathing. They're not like you and me. They don't breathe on a regular rhythm. So you need to count for a full minute, not do what we usually do for adults, which is count for 15 seconds and multiply by 4. So this might take you a little bit longer. Just have to keep that in mind. Next is our blood pressure, which typically we don't do on healthy newborn infants. This will be done if they go to the newborn nursery. Oh, hold on, losing my slides here. If they go to the NICU, they'll have a blood pressure, or if there's a cardiac defect that's expected. Obviously, you want to perform a weight. You want to do it at the same time every day, preferably with the same scale to get consistency. Length is from the head, all the way down to the bottom of the heel. You may need a second set of hands to do the length because sometimes the infant doesn't want to completely stretch out for you, and it's kind of hard to balance a measuring tape and the infant at the same time. Length will be recorded in centimeters, by the way, just to keep that in mind, and you might have to convert that for mom and dad. Then we do our head circumference, which you want to measure at the widest diameter of the head. So there could be some molding after birth, but you want to make sure you're measuring at the widest portion of the head. Again, in centimeters. Chest circumference should be at the nipple line. Should be about 2 to 3 centimeters less than the head circumference. And then finally, abdominal circumference, again, not typically done on a healthy term baby. This would be done if there is a reasoning for increased abdominal girth, or if they were going to the NICU. All right, now we're going to move on to our beginning of our assessment, which will be with the head. Molding is a normal variation of a newborn. During the birth, the head is compressed in the birth canal, so it kind of misshapens it. You just want to reassure the parents. Some abnormalities would be swelling, bruising, or bleeding. And then I mentioned here 2 specific diagnoses, which is caput cystadecium. Sorry if I'm not saying that correctly. And then cephalohematoma. I'll explain those in a couple slides here. Fontanelles, you want to feel anteriorly and posteriorly. They should be open, soft, flat, non-bulging. Sutures, they should be palpable, but they should definitely be present and not joined. They could be overlapping, which is a normal variation of a newborn, by the way. And then the hair should be present, silky fine, and variable in amount depending on the race. This is the caput cystadecium. It is a diffuse swelling of the soft tissue over the scalp. This is normal for the most part. Most babies end up having some degree of swelling. You just want to reassure parents that it's going to be okay, that this does go away in a couple days, and there's no long-term negative outcomes from this. This is the cephalohematoma. This is different from the caput because this does not cross suture lines. It is in one focused area, and this is actually a bleeding of the blood vessels in between the skull and the skin. So different from a subdural hematoma, which would be a bleeding between the brain and the skull, which would be more serious indication of a hemorrhage internally. This is just a bleeding of the blood vessels that go between the skin of the scalp and the skull itself. This is also not life-threatening. There's no brain hemorrhage happening here, no effect on the skull itself. But this should resolve. It takes a little bit longer, about a week or 2. So again, just reassuring the parents that everything's going to be okay. Moving on to our ears. So the ears should be placed, the top of the ear should line up with the outer canthus of the eye. You want to note this placement because any abnormalities of the ear could actually be an indication of kidney disorders. So the ears and the kidneys develop at the same time in utero. So if you see externally any issues with the ear, that could be an indication there is internally an issue with the kidney. So that could mean a more serious workup, ultrasounds, things like that. You also just want to make sure that the infant is responding to sounds. They should have startle to loud noises. So just keeping note of that. They will have a formal hearing exam done prior to leaving the hospital though. right. And on to eyes. So we're observing them for their spacing, their size, and their positioning on the face. A blink reflex should be present. Noting the epicanthal folds. This can be a racial characteristic that depends on the parents. You know, kind of look at them to see if it's normal what you're seeing on the baby. If it doesn't line up with the genetics, then you might want to be thinking about chromosomal abnormalities like trisomy 21 and that type of stuff. Make sure there's no discharge present on the eyelids or lower eyelids. That can be an indication of blocked lacrimal duct or of an infection of the eye. Erythromycin ointment is actually given prophylactically after newborns are born to kind of prevent these eye infections, but this can still happen, so you just want to keep that in mind after they're born. And then obviously assessing pupils, making sure they're equal, round, reactive to light, and that there is a red reflex present. Make sure that, you know, internally in the brain that everything is appropriate. Any abnormalities of pupils could be an indication of a hemorrhage in the brain, so just want to keep that in mind. And then some normal variations like strabismus and nystagmus, that'll go away over time. And then for nose, again, just observing that it's midlight, nasal nares are patent. Make sure there's no nasal flaring. Nasal flaring in an infant indicates respiratory distress, so we just want to make sure that nothing is going on there. They are obligatory nose breathers, so you can reassure mom when she's breastfeeding that the baby is going to breathe because he's breathing through his nose, which migrates around the soft tissue of the breast nicely. Sneezing is also very common in the newborn period as they're kind of clearing all that fluid from their lungs and their mouth and their nose. So just, again, reassuring parents is a big thing here. Throat and neck. Infants' throat and neck, you want to observe and palpate. They have a shorter neck with a lot of skin folds, so just making sure you're looking in the skin folds for any rashes or irritation. And then just observing the infant's head, seeing if it's midline, are they twisted towards one side. That could be an indication of torticollis, which is actually shortening of the neck muscle. And this happens just from the position that is the baby's in utero. And this goes away over time. There may be some physical therapy that may need to be needed to kind of relieve that tension, but normally that goes away over time. And then you want to feel the baby's clavicles as well at this time. Make sure there's no crepitus, kind of crunchiness when you're palpating. That can indicate a break of the clavicle, which can happen just from normal, from the birth process itself. And now we're on to the mouth. So mouth, you want to observe first temperature, moisture, color. There should be no circumoral cyanosis after 15 minutes of life. So transient circumoral cyanosis is normal in the first 5 to 15 minutes. So that should be some blue coloring of the mouth and the lips. After 15 minutes of life, the infant should be completely pink on his lips, mouth, gums, nose, face, all of that should be pink. The only thing that can still be normal is the blueness of the hands and feet. And that, again, is acrocyanosis, which we mentioned earlier. You want to then use a gloved hand and palpate the gums and the palate, making sure that there's no teeth or cysts on the gums and making sure the palate is intact. And then you can elicit the rooting reflexes, which the rooting reflex is when you rub the side of the cheek and the infant turns towards that side that you're rubbing. And then the sucking reflexes is when you insert a finger in the infant's mouth and kind of rub the roof of the mouth, they'll instantly start sucking. And then extrusion reflexes is when you place something in the middle of the infant's tongue and they actually thrust outward naturally. And that's a way to prevent them from choking. That's a permanent reflex. So I actually have some links here that you can follow. Just click on them. The first one, rooting, is highlighted. That is actually rooting and sucking reflex. And then extrusion reflex is also underlighted over here. Just to mention about the tongue, make sure it's not protruding. You want to observe for any lip, tongue ties, that'd be a tight frenulum. You can see that sometimes it kind of looks like a little heart-shaped tongue when they start to cry. And that can indicate, they could have a hard time breastfeeding. So just keeping those things in mind as you're doing your newborn assessment and what you can do to help out mom. All right, so now we're going to go to our case study. So this is little baby Nemo. So at this time, I'm going to read the case study to you, and then you'll take a couple minutes to discuss with your friends and your classmates, and then we'll go over the answers. So baby Nemo is a 39-week-old male Born vaginally to a prima gravida mother approximately 1 minute ago. The infant was born with a weak cry but responded to light slapping of his feet with a loud cry. He has some flexion of his arms and legs and his body is pink, but has some bluish coloring of his hands and feet. His heart rate is 110 beats per minute. You are, as his delivery nurse, what is your APGAR score for him at this time, and what interventions are you going to need? So I'll give you guys a couple seconds. So that's right, his APGAR score would be a 7, and at this point you're just continuing to monitor him. He's good, there's no interventions needed, and just make the next APGAR score at 5 minutes. All right, so now it's been 5 minutes, and the infant is responding well. His heartbeat has picked up even more. It's at 135 beats per minute. Sorry, I lost my page here. He is crying vigorously, and he is well flexed and responding to gentle slapping of his feet with a good cry. But his hands and feet are still a little bit blue. So what's his APGAR score now? So his APGAR score is actually 9, so that's good. He's on a good trend as far as that goes. So moving right along. So now you hand the infant back to the mom, and she's beginning to breastfeed, and she's asking you, is his breathing okay, because he is still blue. She doesn't understand why he's still blue. You come over and you assess that his hands and feet are definitely blue, but his mouth and mucous membranes are pink and moist. And so at this point, what do you tell the mom? And I'll give you guys a couple seconds to think about that. So you would tell mom that acrocyanosis is a normal newborn variation, that there's nothing to worry about, that's normal for about 24 hours of life. And even after 24 hours, if the infant becomes extremely cold, they can have decreased circulation to their hands and feet, and they still may get a little acrocyanotic. You would want to reassure mom that this is normal and it should improve over the next 24 hours. And then in addition to assessing just that his mucous membranes were pink, you want to look for any nasal flaring, respiratory distress, increased respiratory rate, and any labored breathing. All right. And then finally, the infant is now 4 hours old. You perform your newborn assessment and note that a caput sussidacium, and explain to mom now what this finding is and what interventions are needed for this baby at this time. So at this time, you want to explain to mom that a caput is a normal newborn finding after birth. It results just from normal trauma during going through the birth canal. It's a diffuse swelling of the soft tissue of the scalp. Some bruising may be able to be seen, and then this should resolve on its own in a few days. No interventions are needed. So just a lot of reassuring of mom, making sure that she knows it's going to be okay and there's no long-term outcomes associated with this, usually. All right, and so now I just want to give you guys a chance to ask any questions you might have. Let me know if anything wasn't clear. We can talk about little things in more detail. Just raise your hand. All right. And here are my references. You guys can look these up. It's our textbook here if you guys have any questions. And thank you for letting me lecture you today.